You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to the December 2025 edition of Editor's Summary. This month, I will be interviewing Doctors Yona Zembia and James Crawford from the Department of Pathology and Laboratory Medicine, Northwell Health, New Hyde Park, USA, who will discuss their paper titled COVID-19 Vaccine Booster Uptake and Effectiveness with Persons with Systemic Autoimmune and Rheumatic Diseases.
Boosters very substantially and significantly decreased severe COVID. The protection against any infection was limited. So to expand on that, severe COVID was hospitalization or ICU admission. Our data is strongest in hospitalization, partly because we have the largest data set, and there was a very significant reduction in the hospitalization rate when patient received the boosters. The ICU outcome also showed a very big reduction in the point estimate. The confidence intervals are longer because we did have a smaller patient population, and that definitely limits the certainty that we could ascertain. In terms of comparing the autoimmune patients to their non-autoimmune, I think that what we see is that the benefit was so big in autoimmune because their baseline is bigger. It's always easier to make a big effect if the baseline is bigger, and that's really what we were able to see over here. You alluded to, did the disease type or the therapy type make a meaningful modification? And I think that's a very complex and interesting question. So in short, I think the most accurate answer is that we didn't see a modification. There was no clinically significant, or even statistically significant difference on either the disease or the drug. In terms of how to interpret that, I do think that experts are going to agree that it has to matter, that, different diseases are going to make a difference and different therapies are going to make a difference. I could say that the difference is not big enough that in our study and in our data, we were able to see it. I think that's one thing we could say. And I would also add that these things are very sensitive to your study design. Our study design was set up to compare with a booster and without a booster. We were not set up to compare this disease versus that disease. And that's also going to limit the statistical significance of what we can see in the output.
I understand. I just want to emphasize, because it's taken me a while to get my head around the comparator groups, that it is patients who receive the booster to patients, not the general population, who received one dose, but not necessarily. In the first study, let's say one dose, but not the booster. The second part, the initial primary immunization, but not the booster. Is that correct? Am I interpreting that correctly?
Yes. Yeah. So this is definitely something worth clarifying. The bivalent booster was coming after patients were expected to have the primary series. Because of that, we compared patients who had the bivalent versus the patients who didn't have the bivalent. However, we were concerned that it might make a difference. Of course, it could make a difference as to what their baseline status was. And for that reason, we put it into the Cox proportional hazard ratio to correct for that. We didn't exclude a patient who did not have the primary, but we accounted for it to correct for that. In the primary series, we really wanted to focus on patients who had the primary series and it was yes booster or no booster. And in the primary series, we actively excluded patients rather than the correction factor.
I hope you enjoyed listening to part of my interview of two of the authors of the paper titled COVID-19 Vaccine Booster Uptake and Effectiveness Among Persons with Systemic Autoimmune and Rheumatic Diseases, and we'll listen to the full interview, which is available at our website, www.jroom.org, and on our YouTube channel. Now moving on to the other articles in the December 2025 edition of Journal of Rheumatology. The optimal treatment choice for an individual with RA is not yet known, and further research is needed. However, it is not clear if patients and physicians have the same priorities for research. The aimer of the paper by Benina and co-authors titled Understanding Patient and Physician Perspectives regarding innovative research in rheumatoid arthritis was performed to address this issue. Using focus groups of both patients and physicians separately, the authors found that different themes emerged. Patients were more concerned with 1, information related to medical management decision-making, 2, necessary behavioral change due to treatment-related challenges, and 3rd, patient-physician relationship as a foundation for constructively approaching shared decision-making. The major decisions that arose from the physician groups were 1, the impact of research on medical management of a patient, 2, the feasibility of RTCs and biomarker-driven trials, and 3, how randomization could challenge shared decision-making with patients. Both physicians and patients were concerned about how being part of research in the setting of a clinical care could disrupt the day-to-day activities and threaten shared decision-making. The next paper stays with the RA theme and is titled Differences in Cause-Specific Mortality in Patients with Rheumatoid Arthritis by Sex and Seropositivity. In this retrospective study, Jorns and co-authors found that 1,337 patients with RA had a significantly increased all-cause mortality as compared to 4,011 people without RA from the same population. This increased mortality was found in both males and females, but did decline after the 1980s. The specific causes of death that were increased in the RA patients were coronary heart disease, circulatory disease, respiratory disease, neoplasm, and genitourinary disease. There was a significant difference in the mortality from respiratory disease between RF positive and RF negative RA patients, but not for the other specific illnesses. There were no differences in the cause-specific mortality between the sexes. There has been a suggestion that clinical drug trials do not accurately represent the diversity of a population seen in clinical practice. In their paper titled Diversity in Axial Spondyloarthritis Drug Trials, Enrollment by Sex, Race, Ethnicity, and Geographic Region, Kofet and co-authors analyzed 59 trials with a total of 16,162 participants in axial SPA drug trials to determine the demographic and geographic diversity of the populations studied. They found that enrollment of women in phase 3-4 drug trials generally reflected the overall disease demographics. The reporting of race and ethnicities in these trials has, importantly, improved over time. The participation of Asian, American Indian, or Alaskan Native, and Hispanic Latino patients has increased over time, but the representation of Blacks and Native Hawaiian Pacific Islanders has remained low. An accompanying editorial: how representative are data from clinical trials in axial spondylitis for women? Doctors Horst, Brunsma, and Van Leuven from Radboud University, Nijmegen, the Netherlands, give an overview of the implications of the findings for the treatment of patients with axial SPA, and emphasize that the lack of diversity in clinical trials does not allow for a reliable assessment for both safety and efficacy of new therapies in all population subgroups. Keeping with axial SPA, the next paper is titled "A Multi-Center Study of Secukinumab Uptitration in Axial Spondyloarthritis, Real-World Evidence," and is by Freitas Nunez and co-authors. This was a multi-center retrospective study that included 106 patients with both radiographic and non-radiographic axial SPA who had received secukinumab 150 milligrams every 4 weeks for at least 3 months, but still had active disease. The dose was then escalated to 300 milligrams, and they found that the ASTAS significantly declined within 6 months of escalation. The response rate was 87.8% in 6 months and 59.1% at 24 months. They did not find any new safety signals. Now move to paper titled "Patient Resilience is Associated with Better Patient-Reported Physical and Mental Emotional Quality of Life in Systemic Lupus Erythematosus," and is by Singh and Beasley. Using data from a prospective study of 945 patients with SLE enrolled from 15 U.S. rheumatology clinics, the authors found that 27% of the cohort had what is described as high resilience. This high resilience was associated with a positive effect on physical function, social participation, anxiety, emotional distress, fatigue, pain, and pain intensity, with a lesser effect on sleep. Compared to SLE patients who had low resilience, those with high resilience were more likely to report very good or excellent health with a lower SLE disease activity measurement. High patient resilience was independently associated with health-related quality of life. Preservation of vision is an important outcome in patients with a giant cell arteritis, or GCA. In their study titled "Assessment of Giant Cell Arteritis Associated Visual Outcomes at a Tertiary Hospital in Ontario, Canada," Dunick and co-authors found that of the 289 individuals with GCA in this retrospective study, 77, or 26.6%, had GCA-associated visual changes. 34% of these 77 patients had a temporary visual impairment that completely resolved. 70% had permanent visual loss, and 16% had improvement. They did not find a difference in the outcomes for those treated, first with intravenous versus oral glucocorticoids. We all know that knee pain increases with aging. In their paper titled Impact of Knee Extensor Power on Knee Pain in Adults with or at risk for osteoarthritis, the multi-center osteoarthritis study, Huang and co-authors examined this issue in 4,712 patients with or at risk for knee OA. They found that patients whose knee extensor power was in the weakest quartile had a 1.35 odds of worsening knee pain severity and a 1.93 odds of incident frequent knee pain. These findings suggest that targeting knee extensor power may reduce the risk of incidence and progressive knee pain. As rheumatic complications of cancer therapy have become increasingly recognized, this month we are happy to publish a two-part living guidelines from the Canadian Rheumatology Association, Canadian Research Group of Rheumatology in Immuno-Oncology. The papers are titled Canadian Rheumatology Association, Canadian Research Group of Rheumatology Immuno-Oncology Living Guidelines for Baseline Immunosuppressions in Preexisting Rheumatic Diseases, Initiating Immune Checkpoint Inhibitors, Part 1, Preexisting Inflammatory Arthritis, and Part 2, Preexisting Systemic Autoimmune Rheumatic Diseases. This month we also published a systematic review and meta-analysis on the same subject, titled Necrotizing and Non-Necrotizing Granulomatous Reactions in Cancer Patients Treated with Immune Checkpoint Inhibitors, a systematic literature review by Wang and co-authors. We have two very special editorials regarding the potential implications of the changes in U.S. funding for research grants implemented by the current U.S. administration. The first is titled Science in Peril and is by Dr. Richard Panish from the Keck School of Medicine, University of Southern California, Los Angeles, USA. And the second is by Drs. Juan Schmuckler and Theodore Pincus from Rush University Medical Center, Chicago, USA, titled, Could Some Medical Developments Over the Last 60 Years Explain in Part Conditions That Led to the Current U.S. Administration? These two editorials make for very interesting and provocative reading. This month's Rheumatology Around the World paper is titled Establishing Centers of Excellence for Psoriatic Disease in Latin America, Consensus Recommendations from the Real Panlar Group. Paper for Panorama, 360 Degrees of Rheumatology this month is titled Sabbatical in a Pediatric Rheumatology Unit in India and is by Dr. Uzil, who reflects on the differences in practice of pediatric rheumatology between his home country of Israel and India. There are two images in rheumatology this month. The first is titled Tenosynovitis with rice body formation, which shows an MRI and operative photograph findings of rice bodies in the flexor tendon of a dairy farmer who presented with swelling of hand and wrist. Cultures grew Mycobacteria cancyii. The second image is titled A Diagnostic Challenge, Palatal Nodules as a First Sign of IgG4-Related Disease. And the images show pictures of the hard palate, which had progressive enlargement of the lesions, and the pathology from the lesions on the hard palate. There is one research letter titled Racial and Ethnic Disparities in Disease-Modifying Anti-Rheumatic Drug Use Among Adults with Rheumatoid Arthritis in the United States, and is by Ara and colleagues. We also published a case report by Awe and colleagues titled Parvovirus B19-Associated Large Vessel Vasculitis in an Immunocompromised Patient. I want to thank you all for listening to this podcast and encourage you to read the complete articles in the December 2025 edition of the Journal of Rheumatology. These articles are available both in our print and online editions of the journal. The latter is available at www.jrheum.org. And please watch my interview with the authors of the highlighted article this month and previous month's interviews if you missed them. They are available at our website and on our YouTube channel. If you have any comments or questions of any of the articles in the Journal of Rheumatology, please send them to manuscripts@jrheum.com. And please join me in the new year for the January 2026 edition of Editor's Summary. And although this is a little bit early, I wish you all a happy and good new year. And thank you for listening.